Guys, welcome back to another lecture of Dental Pathshala, where we help you understand and learn dentistry better and easy way. And this is a continuation of the express revision course for oral surgery. And today's lecture we are going to talk about the osteomyelitis, which is the infection of a bone. So as the name suggests, itis means the inflammation. Then we have the osteo word, which represents the bone. And myelitis means that marrow. So basically, osteomyelitis is an infection or inflammation of a bone marrow. But it doesn't stop at the bone marrow. It progresses towards the periosteum of a bone. So if we take a cross section, so as we know that osteomyelitis is an inflammation of the medullary space of a bone marrow, or we can say the myeloid space of the bone. So basically it's an inflammation of the bone marrow, but it can progress up to the malignancy. So let's take a long bone and we cut this long bone. So if we look at the cross section of a long bone, we find inside this long bone this cavity which is sparsely placed. So basically there is a lot of air space which is present, and this particular type of bone is what do we call a spongy bone or a trabecular bone, and this is a lightly packed bone, so it makes the bone lighter. Outside this we have the cortical bone, so this the compact bone. So this particular bone which is very densely packed is our compact bone. So compact bone made up of a unit of a bone which is known as the osteon. As you can see, if we take out one osteon, so this one unit is what do we call the osteon or the Haversian system. And in this Haversian system, we find that there are canaliculi. As you can see over here, we have, say suppose this is an osteon. We have taken out osteon. Inside this we have the osteon is also known as the Haversian system. So inside this Haversian system there is this Haversian canal, which along this canal we see that the nerves, blood vessels are passing by, right? So the nerves and the blood vessels. Then these canaliculi branch from the canal to the empty spaces. So these empty spaces are known as the lacunae, which houses the osteocytes and connect to the other osteons. So guys, what happens when there is a odontogenic infection? So in case of a tooth infection or a failed root canal treatment, any tooth infection, or a fracture of a maxilla of a mandible, these are the most common causes for osteomyelitis. How this osteomyelitis infection of bone is occurring? Most of the time it is due to the infection in the tooth. It can be due to the fracture of maxilla or mandible, but the most common being odontogenic infection. It can also be the fracture of jaws, maxilla and mandible. Then what happens when there is an infection? We see that inflammation process starts, right? And because of this inflammation reaction, there is increase in the blood flow to the affected area. So we see that hyperemia. That means increase in the blood flow. Hyper means increased. Emia means the blood flow. Whenever there is inflammation, we see that the inflammatory cells come to the particular site to fight against the infection. So there is increase in the leukocytes in order to kill the bacteria, to fight the infection. This is a normal inflammatory process, right? But what happens in case if there is an altered host immunity? That means the person immunity is not sufficient enough to fight against the infection or the bacteria. That means the immunity of the person is bad. Say suppose if that person is having any disease like multiple systemic disease, Most common being the diabetes. Or if a person is having autoimmune disease, like AIDS, or if a person is malnutrition, or if a person is having medications or on drugs. Certain kind of drugs also alter the response, right? For example, steroids, they decreases the immunity of an individual. Or if a person is having bisphosphonates, right? Either the person's host immunity is altered, that means the person is having low level of immunity, or if there is any altered blood supply. So it again, like a radiation therapy which reduces the blood supply to the particular area. Or if a person has any bone pathology like osteopetrosis, osteoporosis, Paget's disease, fibrous dysplasia, etc., right? So that all these conditions also predispose the individual to certain infections in the bone. So what happens if the immunity is not working properly for that individual? The leukocytes cannot fight and kill the bacteria, so infection from the teeth reaches to these lacunae which we talked about, right? And the bacteria are not getting eliminated from the body. So we have still the bacteria in our body, we can say bacteremia. So bacteria cannot be eliminated. And in response to this, there is a subsequent inflammatory reaction in the bone marrow, and result of this subsequent inflammation, we see there is a pus formation. Since this infection had started from the medullary region of the bone, so there is increase in the intramedullary pressure. So inside the bone, say suppose this is a long bone, right? Then inside this long bone we have the bone marrow, and since the infection has started from the bone marrow, it reaches up till the periosteum. Say this is the periosteum of the bone. So it reaches the cortical bone, it invades into the periosteum. Let's draw it from other color. So from the bone marrow, infection goes to the cortical bone, invades the periosteum of the bone also. Since it starts from the medullary region, so there is increase in the pressure in the medullary region of the bone. So there is increase in intramedullary pressure and decrease in the blood supply to the bone. Since there is reduced blood supply, the bone becomes avascular. Now that the bone is not getting enough nutrition, not getting enough blood, so the bone starts dying, which we call it the necrosis of the bone. So this is the whole process of the pathology of the osteomyelitis. So it starts from an inflammatory reaction. As you can see, then there is a bacteremia. So in osteomyelitis, there is an inflammation which leads to infection, and the most common bacteria, let's write it here, which is involved in osteomyelitis is Staph aureus. This is the most common bacteria. Apart from that, we have the anaerobic bacteria and the Mycobacterium TB, tuberculosis. These are the two important bacteria which are involved with the osteomyelitis. The most common being the Staph aureus. So Staphylococcus aureus. This you have to remember it, because again question can be asked from this particular point. And as we know that this is an inflammatory reaction. Now if you see, we have started with the inflammatory reaction. How do we define inflammation? What we have studied in pathology is that there are 4 signs, cardinal signs, 5 signs. One is the functionalisa. So we see that rubor, tumor, dolor, calor. So there is going to be, because of these signs of inflammation, rubor means redness, tumor means swelling. So there is going to be swelling, but which is quite less. Then dolor, we have the pain in the localized area. Calor means there is increase in the temperature of that individual. All these things we see are associated with the osteomyelitis of the bone. Now again remember one more point, which is that the osteomyelitis incidence is higher in the mandible as compared to the maxilla. And the reason being that is there is dense cortical plates in the mandible, which are poorly vascularized. Since the bone is very dense, there is reduced blood supply, and the inferior alveolar nerve supplies the mandibular bone, right? So primarily it is because of the inferior alveolar nerve. As the person progresses, because there is a periosteum of the bone which majorly supplies the mandible. So if we compare the maxilla to the mandible has got less blood supply compared to the maxilla. Maxilla has got excellent blood supply because it is coming from multiple nutrient feeders vessels. So also the maxillary bone is less dense. So what happens whenever there is infection or inflammation in the maxillary bone, say suppose this is the maxillary bone. So since the cortical plates are very thin, so infection is not sitting deep inside the bone, it is escaping out of the bone, right? Because of the coarse or less dense trabeculae. While on the other hand, in the mandible, the cortical plates are very dense. So the pus cannot escape out of the cortical bone. So it stays, all the infection stays inside the bone, and the bone starts getting necrosed. So talking about the classification of the osteomyelitis, we have several classifications for osteomyelitis. So it can be classified as suppurative or non-suppurative. Suppurative means there is pus or edema in the marrow space, means pus. Non-suppurative means instead of pus there is decreased medullary space and there is more new bone formation. So we don't see any pus in case of a non-suppurative. So in the suppurative you will also find the fistulas, sequestrum. Sequestrum is basically a dead bone. While in case of non-suppurative, since there is no pus, we do not see any fistula and all. Another classification can be hematogenous based on the spread of infection, how the infection is spreading, the focus of infection. If it is from the blood, it is hematogenous. If it is secondary to another focus of infection, it is secondary. Also, we can classify the osteomyelitis into acute and chronic. So how do we classify the acute and chronic? So acute is when there is a presence of infection up till 1 month. After 1 month we call it the chronic. So after 1 month it is chronic. And chronic also we see primary and secondary. And in between we also have subacute phase. So the process is that first of all a person is having acute infection. That means this is the first time the person has got osteomyelitis, either due to medication or any fracture in odontogenic infection. So when the person is having the osteomyelitis infection in the medullary space. For the first time we call it the acute phase. Then we have the subacute phase. We are going to study one by one in detail. Then we have the chronic. If we have not treated it, it proceeds to the chronic. This chronic is the secondary chronic. Now sometimes what happens, in this acute symptoms are very mild and we cannot calculate or we cannot see that there is osteomyelitis because the symptoms are very mild. So a person is not visiting the clinician. What happens, the first time whenever there are signs and symptoms develop and the patient notice or we diagnose this kind of osteomyelitis, we call it the primary chronic. So what happens when there is an inflammation in the medullary cavity of the bone? The host immunity is not sufficient enough to fight against this infection, which is due to Staph aureus. See, there are many bacteria which are involved in the osteomyelitis, the most common being the Staph aureus. So Staphylococcus aureus is the bacteria which is most commonly involved with the infections of the bone. And in case of osteomyelitis, the second most common being Mycobacterium tuberculosis. Since we are telling that the infection is from the Staphylococcus aureus, so this is the reason the first course of antibiotic which we start is the penicillin antibiotic. And also there are anaerobes bacteria which are also involved with the osteomyelitis, and this is the reason along with the penicillin we give the metronidazole, so to fight against the anaerobic bacteria. Now talking about when the body immunity cannot fight this bacteria, there is a formation of a pus and there is increase in the medullary pressure in the bone. So there is increase in the intramedullary pressure. There is infection in the medullary cavity or the bone marrow. And this particular kind of situation is what do we call the acute suppurative, since there is a pus formation, suppurative. So the first time the symptoms we can say, what do we see is pain if in the tooth, respective tooth we can say, which is causing the odontogenic infection. And the pain is basically kind of a deep, intense and boring pain. We also see intermittent high fever. And the patient is not able to open or close the mouth. So it is painful. The patient is having trismus. Since the patient is having fever, so there is a malaise. So these all are basically the signs of inflammation. We see increase in the leukocytes. So leukocytosis. Also there is increase in the ESR rate and the C-reactive protein rate. This is within 1 month. So if I say that infection is within 1 month in the medullary cavity, so acute suppurative means the infection is in the medullary cavity and since this is early infection, we cannot see much of the radiographic changes since there is not much destruction of the bone that it is appreciated in the radiograph. So somewhere after a month, after 15 days, half a month time, if it is not treated, it proceeds to the subacute suppurative. So let's say 2 weeks of time. Acute, subacute suppurative. Since I am telling that this is suppurative, that means that the patient will have pus in the bone. So now the infection has left the medullary cavity and it is spreading in the periosteum of the bone. That means from the inside, so if you look at the acute suppurative phase, the infection is in the medullary cavity. Right. Now in case of subacute suppurative, you will find that the infection is spreading into the periosteum of the bone, right? So in the acute phase, there are all signs of inflammation we see. So there is redness, pain, increase in the temperature, that is fever, high fever, right? So in the subacute suppurative phase, like after 2 weeks of time, the fever starts coming down. So what are the features which we see is the cellulitis. There is swelling in the respective area where there is a odontogenic infection or there is fracture. Whatever the etiology is, the respective area you will find fistula. Since the infection has started or invaded into the periosteum, so you will also see that the periosteum is enlarged. So there is expansion of the bone and the tooth starts moving. Also there are lymph node enlargement, so lymphadenopathy, tooth mobility, and the bad breath. So in the radiograph, you will see that there is a widening of the PDL, since there is a tooth mobility, right? So in the radiograph, there are lytic changes which starts appearing in the bone. So the bony trabeculae becomes fuzzy and indistinct, and there are also radiolucent areas which we start seeing in the subacute suppurative phase. So if the subacute suppurative phase is also not treated, it is left untreated, then it proceeds towards the chronic. So then it starts with the chronic secondary, right? Since it is coming from acute phase, so after a month's time, we see that there is pain and tenderness on palpation. So also we see there is swelling, fistulas, and sequestrum. And sequestrum is dead dense bone, always remember. Since it is dense bone, so it will appear as radio opaque, white, that means white. In the radiograph, you will find the moth-eaten appearance. As you can see in this diagram of a picture of this leaf, the moth has eaten whole of the leaf. So there are spots in between, some kind of irregular spots we see. So this is a moth-eaten appearance, right? Now what happens when there is almost no symptoms which are associated? So that is known as the chronic primary. It is usually asymptomatic. So when there is little symptoms, or we can say asymptomatic acute phase. Asymptomatic acute phase. That means the person has not noticed because there are no signs and symptoms, so it will progress into the chronic primary. In the chronic primary, you will see mild pain associated in the odontogenic area. There is no fistulas and there is a sequestrum. So which is sequestrum is our dead bone, right? This was about the suppurative infections. So let's talk about the non-suppurative infections. In the non-suppurative infection, we can have two kinds. One is focal. So as the name suggests, focal means, another one is diffuse. As the name suggests, focal means it is confined to one teeth. So basically confined to a specific teeth, which is carious or grossly decayed, like that. Diffuse means that there is no single teeth which is involved. Instead of that, there is periodontal disease, large number of teeth, right? The infection is not through the pulp or the carious teeth. Instead of that, infection is from the periodontal attachment. So it is usually seen in older individuals, especially the edentulous denture wearer patient. Since this swelling is diffuse and because of the periodontal disease, so we will see that there is diffused opacity of the bone, and the bone looks like the wool of a cotton. So cotton wool appearance. And very difficult to differentiate the normal bone and the sclerosing bone, since the normal bone is also radio opaque. Now talking about the focal, when the infection is confined to a grossly decayed teeth or a carious teeth, that case we call it the focal nonsuppurative, or you can also say it the condensing osteitis. So what happens in case of a focal or a local? The entire root outline is visible. Also we see that the lamina dura is intact, which is missing in case of a benign cementoblastoma. So in this case here, in the condensing osteitis, the most common teeth which is involved is the mandibular first molar. Since we know that first molar has got high carious rate, and the mandible is also involved more in the osteomyelitis. So when the tooth is confined to a grossly decayed or a carious tooth, we call it the focal. So in this case you will find that the tooth is carious. Say this is a tooth, mandibular first molar. This tooth is carious, okay. The caries start invading via the pulp, then goes into the bone, right? So if you see that there is well circumscribed radio opaque mass of a sclerotic bone which surrounds the apex of the carious teeth. So you will find that there is radio opacity which is present. Opacity. Mass of a sclerotic bone which is well circumscribed. So if you see in a radiograph, you will find the appearance which is a moth-eaten appearance. Right. There are two kind of pattern. One bone is which is already dead, which is known as the sequestrum. So let me write it here, guys. The sequestrum is basically a dense dead bone, right? Dense dead bone, which is basically white and light in radiograph. So that is radio opaque. And surrounding this radio opacity, this is sequestrum. Surrounding this radio opacity, you will find the radio dense mass, which is our involucrin, which is our new periosteal bone. So as you can see, a rim is formed. So this rim is known as the rim sign. So you will find well-defined trabeculae of the medullary bone are lost, and since they are lost, the pattern of the bone is like a patchy moth-eaten appearance, as if the moth has eaten, as I've shown you in the leaf. Is if you can see here, the leaf which is eaten from surfaces from inside. So like that you will find. If you can appreciate over here in this diagram, you can see here this one. So the normal anatomy of the bone is lost since there is infection in the medullary cavity. Then it invaded into the periosteum of the bone. As you can see, the periosteum of the bone here is infected, and in between you can see this white spot. If you can appreciate, guys, these white spots, these all white spots are the sequestrum. The radio opaque mass. So this is also radio opaque mass, right? So these are the sequestrum. Then surrounding this you will find the, if you can see over here, the white bone, and it has invaded the periosteum. Here you can see it has invaded the periosteum of the bone. So basically the sequestrum and involucrin also you will find, and the appearance is the moth-eaten appearance in a radiograph. This you should remember, that the moth-eaten appearance is seen in case of osteomyelitis of the bone. We also see some non-suppurative conditions or lesions like chronic osteomyelitis with proliferative periostitis. That means instead of going into the necrosis, the bone, in result to the inflammation, start reacting. So that is the reactive lesion. So instead of going dead, the bone starts proliferating. So this condition is also known as Gary's osteomyelitis, since it was given by Gary. Because of the osteomyelitis, a chronic osteomyelitis, long-standing osteomyelitis, you can see there is inflammation of the periosteum, which is the outermost layer of the bone. In response to this inflammation, there is new bone formation in response to this irritation. Hence, it is also known as the periostitis. That means inflammation of the periosteum ossificans. So in response to this inflammation or infection, there is new bone formation which is occurring, and we also see there is thickening and hardening of the bone. So sclerotic bone, you will find the sclerotic bone, which is basically hard, dense, thick bone, hard bone. So you will find that there is bony, hard swelling of the jaw. Especially this Gary's osteomyelitis we find in children because the periosteum is very loosely attached to the bone surface. So that is the reason that radiographically, if you see, you will find this dark and light band at the outer cortex. So guys, this is basically the moth-eaten appearance. So if you can appreciate, there are sclerotic bone, and surrounding these sclerotic radio opaque white bone, which is the sequestrum, surrounding this there is involucrin. Now we were talking about the Gary's osteomyelitis. So since there is a bone growth at the outer cortex, say suppose this is the cortex of the bone, periosteum of the bone. So because of this osteomyelitis or chronic osteomyelitis, long-standing osteomyelitis, instead of going into necrosis, the bone starts proliferating. So you will find that the bones start growing at the outer cortex. So like this, in layers, like a skin of an onion, like how we peel the onion, and how there is the appearance of the cortical bone is like a peel onion. So that is the reason we call it onion peel appearance in a radiograph in case of Gary's osteomyelitis. So you will find this radiopaque and radiolucent lines. So you have to either go for root canal treatment or extraction for this grossly decayed teeth. Now talking about the diagnosis, how we diagnose osteomyelitis is basically a CT scan. You will find that there is a cortical erosion of the bone. Also, you can do the nuclear imaging. With the technetium 99 scan. Along with that, we add gallium, basically contrast agent. These agent will differentiate the areas of infection as these agents binds to the WBC. So these contrast agents are gallium 67 or indium 111. Now let's talk about the treatment for osteomyelitis. So as it starts from the acute, right? So in the acute, we give antibiotic first, which is IV antibiotics, which is basically our empirical therapy. So we give most of the times penicillin G 2 million unit, which we are giving IV, right, for every 4 hours. Plus along with that, this penicillin is for Staph aureus, right? Along with that, there are anaerobic bacteria also. For that, we give the metronidazole 500 mg. This also we give IV for 6 hourly, right? Now, first of all, we give this antibiotic, which is our penicillin. Now, after 2 to 3 days, we start giving this antibiotic in oral form. The same antibiotics in the oral form, which is 500 mg both. Right. In case if a person is allergic to penicillin, we can give the clindamycin or cephalexin. Right. Now, this is for when the person is coming for the first time with the osteomyelitis. So for after 2 to 3 days, we have to treat the cause. So after 2 to 3 days, first of all, we give the antibiotic orally. Then the next step what we do is we start treating the cause. If it is due to odontogenic infection, we go for either root canal treatment or the extraction of the teeth. If there is pus, then we go for the culture sensitivity. We check which bacteria is involved so that we can give the correct antibiotic. So we give the respective antibiotic according to the culture sensitivity. We give it for 4 to 6 weeks. Now, here we have two situations. One, if the patient recovers, then we don't have to go for any treatment. If the patient is still with the disease, then it proceeds to the chronic phase. So then we have to treat surgically. So if the person is having loose teeth, then we call for extraction. If a person is having any fistula, we go for incision and drainage. If there is small sequestrum, Then we only remove the part of the sequestrum. We call it the sequestrectomy. That is removal of the sequestrum. If the lesion size or sequestrum is normal or moderate, so if we are extending the bone removal, then we are doing the saucerization. If there are large lesions, we do the decortication. That means removing the cortical bone also. So sequestrectomy is basically we are just removing only a small, well circumscribed part of the bone. The bone which is necrosed, the part of the cortical plate which is infected, which is avascular, which is necrosed, we only remove the part of that small sequestrum. We call it the sequestrectomy. Saucerization is along with the infected bone, we are removing the adjacent cortical bones also, and we leave it open. So the classical treatment is sequestrectomy or saucerization. Basically our main aim is to remove the necrotic bone, remove the poorly vascularized bone. So sequestrectomy is only removing the infected avascular bone, basically only the cortical part which is necrosed. Saucerization is we are removing the infected bone as well as we are removing the adjacent bony cortex which is involved with the infection. Decortication is when we are removing a large bony fragment. So a chronically infected bone or very poor vascularized, in that case we are removing the cortex, periosteum, up to the medulla also, medullary bone also we remove. So these are the classical treatment surgical protocols. Along with that, say suppose if I am removing a large chunk of bone and very small, say suppose this is the part of a bone which is this much part is necrosed. Now what happens if I remove this particular part of the bone? Say suppose I've done decortication, I've removed this much part of the bone, right? Now since this bone is so thin, it can fracture any time. In order to prevent fracture, we give the reconstruction plates, or external fixators. Also we can give if the systemic antibiotic therapy is not working, we can also give the adjunctive treatment. Which is basically local antibiotic therapy, high doses. So we either do it via wound irrigation system, we open the wound and we irrigate the antibiotic to the necrosed or to the removed part of the bone. And the another one can be impregnated beads. So basically we are taking beads of antibiotics and placing it at the local site. Sometimes we have to go for the hyperbaric oxygen therapy also, in case of treating the refractory osteomyelitis. Hyperbaric oxygen therapy. So it works via increasing the oxygen level of the tissues so that it can fight against the anaerobic bacteria. So this is about the osteomyelitis, wherein there is inflammation or infection of the medullary part of the bone which progresses till the periosteum. So in case of osteomyelitis, you have seen sequestrum, which is the dead bone, and the involucrin and the moth-eaten appearance of the bone radiographically, and the surgical treatment procedure involved the sequestrum and the saucerization procedure. We have also studied decortication under it. So guys, this is about osteomyelitis. Next video we are going to talk about the osteoradionecrosis. Hope you have enjoyed this video. So if you have enjoyed this video, give it a thumbs up. Also comment in the comment section below. This motivates me to put more videos for you guys and to make free notes. So till then, keep reading, keep learning, stay motivated. I'll see you soon in the next lecture.